learn the signs and symptoms of anemia in pregnancy, also to learn prevention of anemia, to know the supplementation of oral iron during pregnancy, how to manage a case of anemia during pregnancy, what should be the management during labor and delivery if a woman who is anemic comes to the labor room, nutritional anemia control program, and also the postpartum contraception. So anemia is one of the commonest disorder in pregnancy. Prevalence in India and also in Pakistan varies between 50 to 70%, and the prevalence in USA is 2 to 4%. Nutritional anemia or the iron deficiency is the commonest form. And we can also say that anemia is the most important contributor to maternal and perinatal morbidity and mortality as a direct or an indirect cause. Anemia is defined as a condition where circulating levels of hemoglobin are quantitatively or qualitatively lower than normal. In a non-pregnant woman, if the hemoglobin levels are below 12 gram percent, then it's anemia. But in the pregnant woman, according to World Health Organization, if the hemoglobin level is less than 11 gram percent, then it is labeled as anemia, or the hematocrit is less than 33%. According to the Center of Diseases and the pregnant woman, if the hemoglobin level is less than 11 gram percent in the first and the second and in the third trimester, that would be labeled as anemia. And in the second trimester, if the hemoglobin level is less than 10.5, then she will be called as anemic patient. Indian Council of Medical Research also defines the severity of anemia on the hemoglobin values. It will be mild anemia if the hemoglobin levels fall between 10 to 10.9 gram percent. It will be moderate if it is between 7 to 9.9, severe if it is less than 7 gram percent, and very severe if it is less than 4 gram percent. Now coming up to the causes of anemia in pregnancy. What could be the causes? So most important is the nutritional deficiency, and there comes the iron deficiency anemia. Again, if before getting pregnant mother has a poor nutritional status, then more likely chances then this nutritional deficiency will continue in pregnancy and she would have low hemoglobin levels. Beside iron, folate and B12 deficiencies are also important, and we will talk about that later. Chronic blood loss due to parasitic infections like hookworm and malaria, multiparity, and also if there is the interval between the pregnancies is less, multiple pregnancy, acute blood loss during any pregnancy like antepartum hemorrhage, postpartum hemorrhage, recurrent infections, urinary tract infections. They also cause anemia because of impaired erythropoiesis, which is formed in the kidney. Hemolytic anemia is seen in the cases of pregnancy-induced hypertension, hemoglobinopathies like thalassemias and sickle cell anemias, and aplastic anemia is rare. Now, pathophysiology of nutritional anemia in pregnancy. There is augmented erythropoiesis in pregnancy. We all know the physiological changes which occur in the pregnancy. The blood volume increases to 40 to 45%. There is increase in the plasma as compared to the red cell mass. That leads to hemodilution and decrease in the hemoglobin levels. Iron stores are depleted with each pregnancy. Too soon or too many pregnancies result in higher prevalence of iron deficiency anemia. There is extra iron requirement and loss during pregnancy. During pregnancy, total of around 800 mg to 1000 mg of extra iron is required. About 300 for the fetus, 50 for the placenta, 400 to 500 mg iron is required to increase red cell mass. Plus, there is blood loss, 250 mg during delivery and 220 for example, for the basal losses. Though there is conservation of iron also about 400 milligrams, because during 9 months of pregnancy there is no menses, and also there is contraction of blood volume after delivery. So if we plus all the numbers in the columns and then we subtract 400, so around average 800 to 1000 milligram of extra iron is required. Now we must know what are the factors which are required for erythropoiesis. Proteins are required for the synthesis of globin, minerals, iron for the synthesis of heme. Also hormones, erythropoietin, which is produced from kidney, it stimulates the stem cells in the bone marrow. That's why if there is problem in the kidney, like we said, repeated urinary tract infection, then the hormone level is affected and there is decrease in erythropoiesis. Other hormones, thyroxine and androgens. Plus, we also need trace elements like zinc, which is very important for protein synthesis and nucleic acid metabolism. Cobalt and copper are also the trace elements which are required. Vitamins, vitamin B12 required for the synthesis of RNA in early stage. Folic acid is required in later stage for DNA synthesis. Vitamin C is necessary for conversion of folic acid to folinic acid, and it enhances absorption of iron from small intestine. Pyridoxine, that is a B6, is useful adjuvant in erythropoiesis. And vitamin A is required for cell growth, differentiation, and maintenance of an integrity of epithelium and immune function. Now we will talk about the pharmacokinetics of iron and the daily requirement. And as you can see in the diagram, the daily diet contains around 10 to 20 milligrams of iron. Then how much is absorbed? 1 to 2 milligrams of iron per day is absorbed. And then it is through the transferrin, the iron is then transported, and we can see that it is going to the bone where hemoglobin is formed and erythropoiesis takes place in the bone marrow, and also the stores are in the liver and the heart in the form of ferritin and also other processes. And so this is the now here the iron is being formed and also stored. There's also loss of about 1 to 2 milligrams of iron per day from desquamization of epithelium. Normal diet contains about 14 milligram of iron. Absorption is about 5 to 10%. That is about 1 to 2 milligram. 3 to 4% in the pure vegetarian diet. Additional daily iron demand in early pregnancy is 2 to 3 milligram per day. In late, it is 6 to 7 milligram per day. That is additional to 14 milligrams. So daily supplementation of 40 to 60 milligram of elemental iron is required during pregnancy, because out of that also only 5 to 10% would be absorbed. Folic acid requirement is also increased because that is also one of the factor which is needed to increase the erythropoiesis. In strict vegetarian, vitamin B12 also becomes deficient, and sometimes we need to give supplements of vitamin B12 too. Now we're coming up to the clinical features of anemia during pregnancy. You can see this chart. We have divided into symptoms and signs. Now symptoms could be if the patient, you can see that there's skin on the skin, we can note that there is paleness, coldness or yellowing. In the eyes also yellowing and pallor. Respiratory symptoms could be that the patient would complain of shortness of breath, weakness, change in the color stool. Central symptoms could be fatigue, dizziness, fainting, low blood pressure, palpitation, rapid heart rate, that is called tachycardia, chest pain, angina, heart attack, and severe anemia. And also in the abdominal examination, if it has been a very chronic anemia, there could be spleen could be enlarged as well as the liver. Now signs, you could see pallor in the conjunctiva, tongue, palate, nail, palm, and in the vaginal mucosa. Colonekia, that is the spoon-shaped nails, dryness and roughness of skin, brittle hair, glossitis, stomatitis, pedal anemia, edema, raised jugular venous pressure, and that is when there is heart failure. Pulse is tachycardic, collapsing pulse, blood pressure, postural hypotension. In the cardiovascular, you could have tachycardia and soft systolic murmur. In the respiratory, tachypnea, fine palpitations at bases of lung. Abdominal examination may reveal hepatosplenomegaly. So again, just a revision of what we talked about, that the clinical presentations depend on the severity of anemia. The high-risk women could be adolescent multiparous who have multiple pregnancies or lower socioeconomic status. If it's a mild anemia that we talked about from when the hemoglobin is between 10 to 11, less than 11, and then a patient could be asymptomatic. But if there is moderate to severe anemia, then the symptoms can vary from like pallor, weakness, fatigue, dyspnea, palpitations, swelling over the feet and body. And then signs could be pallor, facial puffiness, raised JVP, tachycardia, tachypnea, clefts in the lung bases, hepatosplenomegaly, pitting edema over abdominal wall or legs, hemic murmur, cardiac failure, and then glossitis, stomatitis, gelosis, brittle hair, and also colonekia. Now, what are the effects of anemia on pregnancy and the mother? We earlier also mentioned that it is one of the very important cause of perinatal morbidity as well as mortality, as well as maternal morbidity and mortality. So anemia affects both the mother as well as the fetus. First, we will talk about the effects of anemia on the mother. It has been seen if there is anemia, there is higher incidence of pregnancy complications like preeclamptic toxemia, that is the pregnancy-induced hypertension, preeclampsia and eclampsia, abruptio placenta, and preterm labor. Also, the mother is predisposed to infections like urinary tract infection, puerperal sepsis. There is increased risk of postpartum hemorrhage, and that we have contributed because of when there is anemia, then there is proteins are also less, so myoglobin is less, and that is deficient in the muscles, so the uterus muscles won't contract, and there is increased risk of postpartum hemorrhage, subinvolution of uterus, lactational failure, and maternal mortality due to congestive heart failure, cerebral anoxia, sepsis, and thromboembolism. There are effects of anemia on fetus and neonate. There are higher incidence of abortions, preterm birth, intrauterine growth restriction, intrauterine death, low Apgar at birth. Neonate is more susceptible for anemia and infections, higher perinatal morbidity and mortality, and anemic infant would have a cognitive and affective dysfunction. Most critical period is between 28 to 30 weeks of pregnancy, then in labor, immediately after delivery, and earlier puerperia. Congestive heart failure is failure to cope up with pregnancy-induced cardiac load. So this is the most common and grave complication of anemia. That is the congestive heart failure.